Okay, it looks like numbers have started to slow down a little bit, but I think others will continue to join us as we move forward in this webinar. Good morning, good afternoon. Thank you for joining us today. My name is Carrington Lott. I'm the Deputy Director at Systems for Action, which is a national research program office of the Robert Wood Johnson Foundation. At Systems for Action, we're housed in the Colorado School of Public Health and the Health Systems Management and Policy Department. And we host biweekly research and progress webinars where we invite some of the Systems for Action grantees to come and present to a broader audience about their research aims and talk a little bit about what they're learning throughout their research project. Today, we're going to be hearing from a team at CUNY from who the PI is Victoria No. She's here today, and she's going to be kicking us off here as soon as I hand it over to the research team. This is their second time presenting in the Research and Progress webinar series, and they're just over 2 years into their research project. They have one more year left to go, and I think you're going to hear some exciting updates on things that they're learning since they're well into their research project. So we're excited to hear what they have to share on their research project that is titled Multisectoral Task Sharing to Improve Mental Health in Harlem. And I know Vicki, Dr. No, has a couple of her research team members here who you'll also hear from, and they will introduce themselves once we get started. So before I hand it over to the research team to do their presentation, can we go to the next slide, Vidya, please? Just a couple of housekeeping things. We're here today for the welcome, which is going to be very brief, and then I'll hand it over to the research team. They'll have about 40 minutes to present, and then we're hoping that Dr. Bean is able to join us here in a little bit to provide some commentary on the importance of their research project, and then we'll save about 10-15 minutes at the end for questions. So if any questions come up at any point during the research project, please, or during the research presentation, please feel free to locate the Q&A box at the bottom of your Zoom screen, enter in your question, and then we'll make sure to save time at the very end to address all of those questions, and the team will have a chance to provide some answers to those. And one final thing for housekeeping, all of these research and progress webinars are recorded. So we will send out the recording and the slides from the presentation after today's webinar session. So with that, Dr. No, I'm going to hand it over to you.
Thank you, Carrington. Hi, everybody. Good afternoon. I'm Vicki No. I'm an associate professor here at the CUNY Graduate School of Public Health. I also direct the Center for Innovation Mental Health, and I'm PI of this great project. And I'm honored to be able to co-lead this work with Dr. Malcolm Punter, who will be speaking today on behalf of our housing partners. And then Ms. Deborah Levine, who is our connector to the community. She is the director for the Harlem Health Initiative at the CUNY School, and also helps lead the coalition for us. And then we have Dr. Susan Bean, who is the executive medical director for Healthfirst Managed Care. And we're just so excited and honored to be partnered with them because they're really going to help us develop a more sustainable system. And so with that, I can start. Just, a little background on me. I'm a clinical psychologist by training, and much of my work has been focused on mental health task sharing and building capacity in low resource settings and studying implementation strategies for integrating mental health services into a variety of different settings. And I'll pass it over to Dr. Punter, who can introduce himself and share a little bit about his work.
Thank you, Dr. Bean. Hello, everyone. Thank you for joining us today. I'm Dr. Punter. I serve as the President and Chief Executive Officer of a dynamic not-for-profit organization called Harlem Congregation for Community Improvement, where we've been serving the community for over 38 years. We provide affordable housing as well as social services. And one of our signature programs in the health and wellness space is the HIV and AIDS case management and housing program, which we've been funded through a New York City program through the Human Resource Administration for over 27 years. Those families are living viable and sustainable lives based on our services. And this, the Harlem Strong Initiative, is a wonderful and dynamic program that we've been happy to work with Vicki No and her team at this School of Public Health, and is paying dividends already with improving the lives of our residents and the low-income and moderate-income residents in our community. So hopefully you'll hear more from me, and happy to be here today.
Hi, Nora, do you want to introduce yourself for a minute?
Yes, hi everyone. So I am Nora Chavez. I'm the director of Helping You initiatives at Healthfirst. With my experience here has been mostly like collaborating with primary care practices on optimizing health outcomes, access to care, and patient experience, and through the Helping You initiatives, fostering collaborations with community-based organizations to improve population health. And before that, I was a health advocate as part of the Community Service Society Community Health Advocates Program. That's and a community organizer around health, the rights of to healthcare for immigrants in New York.
Thank you, Nora. And we also have Dr. Bean, who may be joining us a little late if she's able to make it. But she has been a wonderful advocate for our project and has really helped us think about, strategies for making this work sustainable. So we thank her for that. And she leads our system coordination, healthcare system part of our portfolio. Great. Next slide, please. We also want to thank RWJF for all of the support you've been providing us. And this work was also sponsored by the NIH Transformative Research to Address Health Disparities, Advanced Health Equity Initiative, and then a small grant from CUNY. Next slide, please. So this work was made possible from the collaboration of over, let's say, like 60, 70 organizations that have been involved with this over the past few years to help support this work. It's made up of community-based organizations, other initiatives that have similar goals around health equity. We also partner with the local city, entities like the Mayor's Office for Economic Opportunity, the Department of Health here in New York City, as well as faith-based organizations and healthcare organizations and behavioral health organizations. We have a number of assemblymen, assemblywomen who are supporting our project as well. Great. So we have several goals for the Harlem Strong Project to address the rising mental health and socioeconomic inequities in Harlem. In our last year's presentation, we shared about our needs assessment and just the unacceptable rates that we're seeing in terms of mental health risk. Over 60% had some indication of depression, anxiety, or trauma, which is quite high. And then nearly 50% had, had housing insecurity, employment insecurity, or food insecurity. So, the socioeconomic inequalities in Harlem are pretty great. So our goals first is to build a coalition, and that's to build a multi-sectoral coalition to support integrating mental health services. And we're in the process of that. We now have over 70 organizations that are part of our coalition. Second is to build capacity for mental health task sharing. And what we mean by that is, providing trainings and supporting the implementation of screening, identification of mental health conditions, educate and coordinate mental health support services. And then we want to increase care access. Our goal is to integrate mental health support into affordable housing, primary care, and community-based organizations. And then fourth is to evaluate the impact of Harlem Strong and assess the implications for future care and policy. So this is our model of care. This is what we're trying to promote in Harlem, and it's basically a approach that we call the collaborative care model. It's a multi-sectoral collaborative care model where housing and primary care are two gateway sites. They are supported by navigators who help connect the community to mental health services that can be offered through housing and primary care, but also, connect them to community-based organizations, faith-based organizations, and behavioral health care organizations. And our program consists of six components to support community resilience. The first is community outreach. Second is screening. Third is psychosocial assessments and risk assessments, client education, and then stress management and wellness skills counseling, and then referral and connections to care. And we're providing training in these areas to support the integration of these components into the work and activities of the organizations that are part of our network. Our research project is actually a hybrid effectiveness and implementation design study that is a step wedge cluster randomized control trial with supplementation. And that was actually changed from our initial proposal, which was to do a smart design study. But what happened during our community planning phase in our first year is that we, got the feedback that most of the organizations did not want to be in the control. All of them wanted to have some exposure to the coalition. And so we switched it to a step wedge design so that it would allow for all groups to have access to basically all the supports. Our study consists of 20 clusters. So sites that are, 20 site clusters, approximately 100 providers, and then 700 consumers. And as I mentioned before, it's a hybrid implementation effectiveness design, which means we're studying both the implementation strategy as well as the intervention effectiveness. And our primary outcomes are to look at effectiveness of the intervention on clients or on consumers. So we'll be looking at depression, access to care, and some of the social determinants as well, and social economic outcomes. And then we'll also be looking at implementation. So we'll be studying reach and adoption of services by the providers within the network. And then we will use a mixed methods design that will include provider surveys at 0, 6, 12, and 24 months, consumer surveys at 0, 6, and 12 months. And then we'll include implementation data and qualitative interviews. The three conditions that we are comparing are the implementation conditions. And so all of the programs are going to get training on the collaborative care model and mental health task sharing. However, how they get the training and how they get the support will differ. So the first group is our education and resource. And so it's an enhanced usual care condition where the sites are given the training, the online part of the training and the toolkit, and they will do what they will with that information. The second group is one where we bring the group together as part of a coalition, and we also provide navigators who are going to be, or we're going to support navigators who are embedded in the housing and the primary care settings, and they will support, residents, consumers to get the care that they need and coordinate care, and the coalition will support the connections across the organizations and help build that network. The third is a supplementation, and so after 2 years of implementing MCC, they'll get an add-on technology, and at this point, it's going to probably be the client management tool that we are in the process of developing. So the step wedge design, the step wedge design is one where we basically randomize our clusters into sequences. So there are 5 sequences. You can see them across the rows. And so the first sequence is one where they start with MCC, and then the second half of, so the study is divided into periods of 6 months, and there are 8 of them. And so for the first group, they will get, across 2 years, the MCC condition, and then the last 2 years, they'll get the technology supplement. You can see here that the second group, we'll start out with just the usual care or usual implementation, which is the ENR, education and resource, and then they get the MCC condition, and then they get the technology, and so on and so forth. And so basically, we are now in our second period. Our first period just got completed, and so one of the groups got MCC and the rest of them got ENR. Currently, we have 2 groups getting MCC and the rest of the groups getting ENR. And so that's how the step wedge works. In terms of our gateway sites, we have 2 types. We have the housing, which consists of HCCI and Hope Community. And then in primary care, we have 4 organizations that are part of that. They're basically FQHCs. And then in our coalition, we have an additional 50 organizations that are community-based organizations, and a small handful of faith-based organizations, and then 15 additional primary care behavioral health organizations. What we do is provide capacity building, and we do this in a number of different ways. First is we provide a flexible hybrid model of training where we offer online trainings as well as webinars to discuss the concepts that they get introduced to online. The online is online videos. And then and all of that is followed by 1 to 2 workshops that are in person. And then we also support the navigators through monthly coaching calls and consultation, with the organizations to support the implementation of the model. We have also started providing navigators and building capacity for navigators. We started an internship program for navigators and are partnered with other CUNY entities, other CUNY campuses to support community health workers to get trained in mental health task sharing and then place them in the gateway sites. And lastly, we provide general capacity building around mental health for the entire community. So our coalition sites are also invited into any of our trainings. In addition to that, we facilitate conversations around issues of priority that the coalition identifies. And so, and for an example, the first coalition we focus on the intersection of faith and mental health. The second coalition meeting is going to be later this month, and that's going to be focused on insurance and public benefit programs and resources around that. We also will be providing or implementing a learning collaborative for the implementation sites, and that's to engage in continuous quality improvement. Next slide. In terms of our training curriculum, it's broken up into 6 modules. We provide an introduction to mental health, stress, and resilience, a module on provider burnout, trauma-informed care and crisis management, community care model, which is essentially collaborative care and how to work together in a team and how to implement the various steps of mental health task sharing. And then the 5th is on counseling and engagement, and 6 is on resilience counseling skills, which is essentially stress management skills. Next slide. We also offer a toolkit, which consists of a resource directory for Harlem, and it's made up of organizations within our network as well as additional organizations to provide a guide around mental health and community resources. We have an implementation guidebook, which also includes flowcharts, checklists, forms to help support the mental health task sharing. And lastly, we have an eHub, which is an online platform, and it's a one-stop shop for training, events, news, and additional resources for the community. Next slide. This is what the website looks like. And the portal is the portal that connects them to the training. Next slide, please. And, we know that this work is very hard to engage in new activities and, new practices. And so we provide quite a bit of implementation support, which includes site implementation planning with the implementation sites. And so that's primarily been the gateway sites. Then we have a navigator intern program that we started just this last year. And our first cohort of interns will be this year, actually, they started in January. And they get placed in the gateway sites. Then we also strengthen the referral network. And so, that's through the work we do with the coalition. But in addition to that, we try to map out the services that are available in Harlem and, make sure that that's included in our directory. And, we provide information about events that are happening within the network to the whole network. We've also been supporting community outreach and working with our navigators and our sites to identify events that are going on in the community that we can integrate our work into. We've, have quarterly coalition meetings, and then we are also starting the process of developing a client management tool that can be used for housing providers to implement mental health task sharing, to support the implementation of mental health task sharing and coordinate potentially the tracking of clients and then the billing of services. Next slide. So we are using a software called Open EMR. It's an open source, free and open source that was originally funded by NIH, and it includes a variety of different features, including, the practice management, scheduling, potentially billing, and there are, just a lot that's already built out. But, we're working on adapting it for Harlem Strong. It also will allow us to generate reports that will help, help support some decisions and programming for the organizations. Next slide, please. This is just like a brief look at it. You can see here the first one is like a patient summary screen and patient demographic forms. Next slide. So in terms of our training, we've made, quite a bit of progress with our first group, that's MCC1. There were 8 navigators as part of that group, and we've just completed that training. And they are now engaged in ongoing weekly coaching. We are starting with our new group, MCC2, and there's 8 additional navigators for that. And there are additional folks that are onboarding. And then the rest of the group are basically encouraged to, to participate in module 1 to 6 online. And there's been some, kind of uneven participation there. Next slide. So here's just a graph that shows a figure that shows basically the participation. The light green is our MCC1, which completed, and you can see the first module, there's more folks that joined, and then we ended up with 7 at the end. MCC2 is our current, and so that participation is just starting, and so those numbers are very low. And then in terms of the rest of the group, mostly folks have been participating in modules 1 and 2, which is, introduction to mental health, and then provider self-care. And then it starts to decrease after that. So you could see here when you offer the training, people don't really participate unless they are getting active support. And we're already seeing, what we hypothesize to be happening. It's already playing out in the pattern of participation and training. Next slide, please. We've also conducted a baseline provider survey, and this is ongoing. We have our biggest cohort that started out at 60, and then as new providers join the program, they are enrolled in the study. And so currently we have 72, and on average they're about, the average is about 47 years, primarily women, 69%, and more than half Black and or African American, 23% Hispanic Latino, 13% white, 10% American Indian, First Nation or Alaska Native, and then 1% of other groups. 17% are born outside of the United States. We are in the process of collecting our 6-month follow-up, and we have 22 completers so far. Next slide, please. And then this is just a preliminary look at, what kind of providers we're getting in our study. So this is based off of like the first group, which is the 60. And you can see here that, nearly 40% are involved in some sort of case management outreach sort of activity. So we have service coordination, case management, counseling, consumer support services, consumer education, and screening and outreach. So nearly half are engaged in, some aspect of that. Fewer, only 13% are providing counseling within this group. 72% work directly with consumers, and 45% also are in roles where they're supervising or supporting direct service providers. The range of folks that the years of work that folks have had in their organization also ranges, but the majority have had at least 2 years. So you can see here about 45, 50, over 50% are 2 years and above, and the 35% out of that group is has been working with the organization for over 5 years. Okay. We looked at stigma of mental illness, and we used the open line scale from the healthcare providers, and we're seeing that for our providers, about 28% are more comfortable with physical illness and mental illness, and 41% report that they wouldn't report their own mental illness to colleagues, and 32% weren't sure. And so, basically what this shows is that there's still a quite high level of mental health stigma even amongst our service providers. Next slide, please. We also looked at mental health risk and burnout amongst our providers. You could see here that we use the PHQ-4. The PHQ-4 is a very short screener that screens for depression and anxiety, and 23% of our providers show mental health distress, and so that's made up of those who report mild and moderate levels of depression or anxiety. In terms of burnout, we use the Maslow's burnout inventory made up of 9 items, and there's 3 factors that are measured. The 3 factors are emotional exhaustion, personal accomplishment, which is like a sense of self-efficacy, professional efficacy, and then the last is depersonalization, which is basically apathy and a disconnection from people and the work. And so you could see with the emotional exhaustion that about 26% report moderate to high levels of emotional exhaustion. So about, over a quarter of our sample are showing moderate to high levels of emotional exhaustion. 42%, or actually 47%, are showing low levels of professional efficacy. So nearly half don't really feel effective in the work that they do, which is quite high. And about 6% report moderate to high level of apathy. And so clearly there's burnout, in amongst the providers that we're working with. And that's one of the reasons why our second module is focused on provider self-care, because we really felt like there was a need to address this issue amongst our service providers. We are also in the process of collecting our consumer surveys. And so period 1 just completed, and we were able to screen 161 consumers, and 70% of those consumers screened positive for mild depression or anxiety. So that's a very high rate of mental health concern in our community. And fortunately, we had 70% of consumers consented and completed our survey. And we're in the process of starting our second round of consumer recruitment next slide, please. We've also been productive in terms of publishing. We have 3 publications on some of our needs assessment data. 2 additional ones are in progress. We presented at conferences, APHA. There's a New York-based one that we presented at in CUNY. And we've also presented quite a bit, probably over 20 occasions, with local organizations and community boards around Harlem and New York City. And now I'll pass it over to Dr. Punter, who will share with us about how things are going with the housing sites.
Thank you, Dr. No. So this work that Harlem Strong is doing was very important to us, and it became evident during the height of the COVID-19 pandemic. HCCI is a property developer and manager, and most of our staff have no training at all in anxiety or identifying anxiety or depression. But we anecdotally experience reports from residents of increases in interpersonal violence, domestic violence, as well as violence and conflict amongst unrelated households and neighbors. We've also experienced, people, particularly older residents, 60 years and older, feeling isolated and fearful, being in a home alone for long periods of time. So the Harlem Strong Initiative, in partnership with the School of Public Health, was timely, and you've seen some of that as evidenced in the formative research that was done, increase in anxiety and depression, interpersonal violence, etc. So what was important to us at HCCI was to make sure that our mainline staff and executives are trained in how to handle these problems that are emerging in our community. And one of the ways we wanted to make sure it is done is by implementing the Harlem Strong Initiative in our housing sites. Our housing is made up of mostly African American, Latino. It trends to the older population, people who've aged in place, and we have responsibility over 100 buildings in the Harlem community. And Harlem is a very densely populated neighborhood. It is not a city; it's a neighborhood, but it rivals in population and density many of large cities throughout the United States. So you can imagine, how intense, the impact of the pandemic and depression was presenting itself. So while HCCI handles the Central Harlem and West Harlem, neighborhood. Hope Communities, our housing partner, really focuses on what is called East Harlem, which skews towards Latin or Spanish-speaking individuals. So we're able to cover in this study, the vast majority of low and moderate income households in on the island of Manhattan, particularly in the traditionally underserved community of Harlem, which is north of 110th Street in Central Harlem. So HCCI staff, as Dr. No mentioned, consist of case managers who, are responsible for, documenting, the conditions of individuals while they're in their housing. But they were not really particularly trained as clinicians, nor did they have specific training on how to identify mental health issues or refer appropriately. So the training aspect of the Harlem Strong initiative was timely and very helpful to us. So we were able to train some of our staff and the staff of the whole community to learn how to navigate, appropriately in partnership with, Healthfirst, a major managed care organization. And then the training curriculum, as was mentioned, was varied and detailed and is ongoing. So we were able to reach a vast majority of our residents in specific buildings in a way that the residents are already looking forward to referral services in our community. So I think the Harlem Strong will continue to make contacts through community navigation, which is really a important aspect of making this process sustainable for HCCI and other groups in the community over time, long after the study has been completed. And of course, as I mentioned, the first cohort of community navigators began offering the referral services this month. HCCI has now been contracted with Healthfirst Managed Care company to provide support for their members and others. And then, the Center of Mental Health and Support with HCCI added additional navigators as needed. The whole community is doing replicating the same process in the East Harlem area. We were able to advocate for staff members to help the Latino community, which is a very important segment of our Harlem community. And we secured funding for the Hope community to make sure that they have the appropriate amount of navigators, and like HCCI will be providing the navigation ongoing through the completion of this study period. Thank you. So I think Nora from Healthfirst give you some more details.
Yes, thank you, Dr. Ponder. Can we go to the next slide? Yeah, okay, good. So Healthfirst has always worked in collaboration with community-based organizations and with healthcare providers with the goal of improving access to care and health outcomes for the populations that we collectively serve. Now, in 2020, under the leadership of Dr. Susan Bean, who's our executive medical director, we began to formalize these collaboration efforts into a cohesive model that we call the Helping You model. Helping You is our model of collaboration with community-based organizations and the healthcare delivery system to improve the health, to improve the health of the populations that we serve by improving, facilitating access to healthcare services, connection and access to social services, and opportunities for self-management skill development in the community. So this Helping You program is structured around 4 pillars: a network of CBOs that are selected based on their track record, their experience and expertise serving specific populations, as well as their cultural and linguistic competencies. These CBOs receive technical assistance through their onboarding and contracting process, and they receive also ongoing training and administrative support once they are part of the Helping You network. We also have another pillar is a standard contract with reimbursement methodology for navigating and health coaching services. One screening tool that is utilized by all partners to identify needs that the network CBOs have capacity to address. And then the last pillar is Hyphen, which is our digital hub, which connects all the CBOs in the network for referrals. It allows for tracking, reporting, and case management. The program screening tool is also in Hyphen, and it triggers referral recommendations when needs are identified, those like referrals based on the network service capacity. Hyphen also provides real-time reports. It permits batch referrals. And now a more recently added feature is it summarizes program activities for partners to use to generate invoices. So this is the program infrastructure. This is what we are leveraging in our collaboration with CUNY Center for Innovation in Mental Health and with Harlem Congregations for Community Improvement for the Harlem Strong project. The Helping You model is versatile. It allows us to use the standard contract and its operational structure to deploy multiple initiatives with different configurations, with different partners, workflows, and that initiatives that are focused on different populations. So to deploy the Harlem Strong program under this model, with this model of operational model, we built on our standard CBO contracting process. HCCI joined the Helping You network, and we created a service crosswalk identifying Harlem Strong activities and their equivalent reimbursable Helping You services like outreach, education, screening, care coordination, and navigation to social services. So we are also collaborating with Dr. No and the CUNY team to connect Hyphen, our digital hub, with the open EMR system that the Harlem Strong Collaborative will be utilizing for client data management. This will permit HCCI to use Harlem Strong's designated platform for screening, assessments, tracking, and reporting, and submit activity reports to Healthfirst through Hyphen for reimbursement purposes. So this is pretty much where we are, and we're looking forward to launching activities under this collaboration model in April of this year.
Yep.
Thank
Great.
you.
Thank you, Nora. Thank you. And we have Dr. Bean. We're so happy to have Dr. Bean here with us. She's really helping to lead us in terms of thinking about health system transformation and how we're going to make this model more sustainable. So with that, I will pass it over to Dr. Bean to make some commentary about the project.
I'm going to apologize to everyone. I'm in the airport.
Oh, wow.
Nora just did an amazing job. I do think, though, that we have been able to have lessons learned from this collaboration that will inform the efforts with New York State and others to actually make these kinds of services, this cross-community, cross-partner collaboration, part of value-informed models. And so for sustainability, that is the way that we'll be able to offer residents holistic approaches to their needs. And obviously, we still want to ensure that as many people as possible have insurance. New York State is wanting this model to be the model that sets the standard, not only for New York State, but across the country. So actually, I'm on my way to New Orleans to talk about Harlem Strong.
Wonderful.
It's a model that is going to be of interest, I think, not only locally, but nationally.
Great. Thank you so much. And thank you for being with us, even though you're at the airport and getting ready to take off. We're so grateful. Thank you. So I guess we should turn over to questions now.
Yes, that sounds great. Thank you so much for the presentation and updates. And Dr. Bean, thank you for joining us from the airport. Very committed. Okay, so we are now in the Q&A phase of our webinar. So we have about 19 minutes here for questions. I do see that one question has been submitted, but if anything came up during the presentation that you'd like to ask clarification on, talk about next steps, feel free to enter your question into the Q&A. Okay. The first question is from David. He asks, what is the relationship mission of the navigators? Is it building relationships over time of trust? Is it to go with the client to appointments sometimes, et cetera? Are there other missions, or just knowledgeable guiding to the right referrals? And then can you talk a little bit about the caseload for each one of the navigators?
Sure. I think it'd be all of the above. Building trust is essential to any kind of helping relationship. And so we actually spent quite a bit of time talking about trust building. And, many of our navigators are folks who are already in the community. And so they already have, trust that's built in some way through their existing roles of supporting community members to, engage in whatever services. So sometimes there are care coordinators that, that's more typical, or community health workers, but sometimes there are other types of folks like resident coordinators, who are more involved in like property management, but, they're taking on this new role. And so in housing, in our housing development sites, those roles can vary quite a bit. And they can be involved in a variety of different tasks, including supporting, folks to get the services they need, through making referrals, as well as supporting them to go to appointments. But the other thing that we've added is the mental health task sharing. So we're training them on how to screen for depression and anxiety, how to provide basic assessments, and identify like higher levels of need. So if there's a severe mental illness risk, then they get referred to a behavioral health provider in our network. They're also trained on stress management skills. We start out with provider self-care, so they practice these skills on themselves first, and then we also help them apply that to whoever it is that they're serving. And we support, just awareness around like the resources that are in Harlem, so that they all are, working off of a network that can, that is more likely to have open services or available services. In terms of caseload, I think it could be anywhere between 1 to 5 clients at a time. It really varies. We're just now starting the implementation. We've gone through 6 months of training now. And so this next phase is implementation, and we'll see how that goes. But the load for screening is much higher, and the load for just like providing outreach, they're all engaged in various activities related to that. But in terms of managing one client, I think reasonably it'll be anywhere from 1 to 5. Great. And then there's a question here about the training curriculum. So the training curriculum consists of 6 modules. We do an introduction to mental health, and then self-care and trauma-informed care, collaborative care, and basically mental health task sharing, counseling skills, as well as specific stress management skills. So that includes things like teaching about mindfulness, behavior activation, problem solving, goal setting, interpersonal effectiveness. And the training curriculum is hybrid. And so for each module, there's about 3 to 4 online videos that are 20 to 30 minutes long. There's a quiz that's built into after each section. After they finish a module, then there's a webinar that follows, 1 to 2 webinars that follow. And we talk about, the application of those skills and those concepts in their work environment. And then the whole series is supported by 1 to 2 workshops that are going to be in person and allow time for like role playing and, demonstrations and things like that. And then that's followed by coaching. So that answers the question that Glenn Milstein asked about training curriculum and how it's implemented. And it's available to all the organizations within the initiative. We focus primarily on our gateway sites in terms of supporting them for coaching and implementation, but any of our online training is available to anybody that is part of the network. And then the organizations that are also service providing organizations and are engaged in navigation, are also welcome to join our coaching as well. Should I just go through the questions, Carrington, or do you
You
want to go
can,
through?
Vicky. I'm happy to ask them out loud to you, or if you just want to address them and answer them, I think you did a beautiful job. So if you want to continue doing that.
Okay, great. So Natalie Harper asked, in addition to housing, what are prevailing social needs among your population? I think insurance is another social needs. You know, we have, I think 40% or so that are uninsured in Harlem. And so, you know, we also want to increase the insurance coverage so that they can benefit from other, you know, the services that are offered through our healthcare system. In addition to that, we saw a fairly high rate of food insecurity. And so there's about 45%. And this was during COVID. This was, you know, the needs assessment we did during COVID. And so we were also, you know, we've also engaged with food pantries and other types of food benefits, you know, that we want to make available to our residents. So in this next coalition meeting, the focus will be on insurance and public benefits. And so that way our navigators and other organizations within the community are aware of the resources that are available, and we can support the connection, you know, to like the organizations that specifically focus on those issues. Thank you. And Lori Yatskill said, thank you for your fantastic presentation. Does diet, exercise, and nutrition play a role in your mental health program? I definitely think it plays a role. You know, in our MCC condition, we're sort of leaving it up to the navigators to integrate whatever, you know, and the organizations to integrate whatever they would like to. And so we actually had some conversations about doing a walking group in one of the, you know, for one of the buildings, and so that they can run a walking group and kind of integrate a little bit of exercise. We have a person who is a navigator who also used to be a trainer, and so he wants to bring in that part of his work. And so we encourage that with our navigators to get creative with their ideas and you know, do as much integration as, you know, as feasible. And of course, you know, we're also partnered with the healthcare organizations as well. And so some of them also offer, you know, nutrition programs. And when there's a need, we certainly make that referral. But I think that's a great idea, and I wish we could do it in a more systematic way. Andrea Germany asked, was this program developed using the World Health Organization PM Plus model? If so, how did having that resource and community healthcare worker training fit into the needs of Harlem Strong? It actually was not used. We didn't use the WHO PM Plus model. That model is a little too extensive for the mental health task sharing work that we want to do. There's too many sessions in that for us. And so we thought it was more feasible to create something shorter. And this is actually built off of some work that I've done in Vietnam and Uganda, where we use more behavior activation. And then we've added other elements like mindfulness, and we've simplified and cut the intervention a little shorter to make it more feasible to integrate. Next question is from Kenneth Thompson, who asked, do your navigators lead, facilitate any support groups? They are welcome to, and we will be supporting that. We have them initially starting with just individual sessions, because that generally is easier for people when they learn a new practice. They're more comfortable just doing it one-on-one, but I think that this work really lends itself to group work and support groups. And so for navigators that are more comfortable providing support groups or group activities, we will support them to implement that. Lisa Kalinsky asked, could you please define mental health task sharing? Great question. So mental health task sharing is a process of task sharing that's specifically focused on mental health. And task sharing is essentially a process where you're taking a more complex, you know, specialty task like mental health or cancer care or, you know, any other kind of chronic disease management, and then simplifying it into more you know, discrete tasks that can be trained in a very clear way. And so, and then in you know, providing non-specialists training to engage in those specific tasks, and then supporting them through like a team-based process. So, you know, that's how we do mental health task sharing. And in our mental health task sharing work, the training involves training them to provide screening. And so we use the PHQ-4 and the PHQ-9. Doing, you know, risk assessments, very brief simplified risk assessments so they can determine the level of care needed, providing basic counseling skills, that are manualized, essentially, structured and manualized. And so the whole intervention is somewhat manualized, so it makes it easier for them to follow. And then they're provided with support from a mental health specialist. Does that answer your question, Lisa? I hope that was clear on what mental health task sharing is.
If people are attending, they won't have the ability to speak up. But Lisa, if you want to just put another question in, and you can comment whether Dr. No was able to answer your question, or if you have any other clarifying questions.
Mm-hmm. And then how are the navigators, Julie Orban asked, how are the navigators found and chosen? They are chosen by their organization leads. And so usually what we do is we engage the organizations. We provide like an orientation to the project, and we, share with them about the trainings that we offer, what the navigator role would be like. And we encourage them to try to see, if there's like an interest in integrating this work into their existing work. And so we were very fortunate that we had Dr. Punter helping to lead this effort, in the housing. And so, then he kind of identified the different roles of folks that were in the organizations. And then depending on whether they were, interested, then they kind of elected to be on. But Dr. Punter, maybe you can speak more to this in terms of how navigators were chosen.
Yeah, I mean, we have existing infrastructure, not clinical in nature, but case management. So we have some folks that, sort of have an interest in this area. So they were able to volunteer pretty readily. And it also helped enhance our skill set for folks, increasing the capacity and sustainability of programs. So what we envision is that once everybody's appropriately trained, we engage with Healthfirst with the data sharing and data management piece. We'll be able to expand our programs that will service people in our community. So it really was a strategic fit and alignment for us. And because we already had the base foundational programs, senior housing programs, tenant coordinators for senior housing, the HIV and AIDS case management housing program, and everything is built around, is wrapped around the housing core, which for our community, based on our history in the community, was really the core issue. And we couldn't really address people's mental health or physical health without having them with a safe place to live. And, the history of Harlem, I guess, speaks for itself in that regard. It wasn't always safe. We didn't have open space, et cetera. And HCCI spent 3 or 4 decades working on that issue, which helps us, now address other modalities for folks living in our community.
Thank you, Dr. Punter. We have a question from Kenneth Thompson, who asks, how long is your training? What is the cost? How do you support navigators while training and afterwards? Is there ongoing supervision and training? Great question. The training, the online part of the training and the webinar and workshop part of the training is about 4 months. And then that is followed by coaching that happens. And so even before we start coaching, we do implementation planning with the organization and, getting the leadership within the organizations engaged in thinking about workflow and, how to make it so that it's feasible and how we can integrate these tasks into the work of the types of providers that are part of the program. And then the supervision and coaching happens, every 2 weeks, every week. It just really depends on what is needed. The last round of training, the last round that we did, we had a slower start. And so we ended up having, it just felt better to have like weekly meetings for a little bit to solidify the group, and then switch over to bi-weekly and then monthly once they get to a place where they're comfortable. And then we have continuous quality improvement. So that's a quarterly, or actually, no, it's a bi-monthly meeting that we have across all the organizations that are implementing the model. And so we do, we share lessons learned during that time. Then there's a question from David Alward. Is the training available for other communities to review and use? We would love for that to be available. We want to finalize it and then share it out after we, work out the tweaks. But certainly, feel free to contact me and we can talk about collaborating. on that. And we have a question from Bridget Hassig. Are the principals in this project familiar with integrative community therapy that have been introduced in the US to train peer-based facilitators in group dynamics supporting mental health and well-being? It's designed to provide community-led options with full access to the therapeutic tool. It's in 40 countries for over a decade. Navigators can gain from having another solution to programs that may be overwhelmed. Thank you. Thank you for that suggestion. We will, certainly share, the resource and see if, organizations are interested in it. We tried to tailor our intervention to fit the specific organizations. And so even though we're using evidence-based practices and we, are using it based off of a model that we've used before, we've had to do a lot of adaptation to make it so that it could work, with the specific organizations. But certainly having, more peer-based models available would be very helpful. Thank you. Then Glenn Millstone asks, is there a salary increase when case managers also become navigators? That's a question that I'll pass over to Dr. Punter, since it'll be his staff.
We're certainly looking for more funding so that we can increase the salaries of the case managers, because most of the case managers we employ live in the community, the low income and moderate income community. So while we try to pay folks competitively, by no means are, in my opinion, people getting paid a above living wage. Maybe they're at the margin. But we do give people an additional stipend that volunteer for the training, as well as to become navigators. I wouldn't call it a salary, but based on our limited budget, we give them some additional funds that would serve them for taking the training. There's another question about financial risk to HCCI. Do you think it will reduce the financial risk for HCCI by making tenants more resilient and thriving? Any services that we could provide to the residents, help them improve their lives, and hopefully, prevent them from, whatever the issues might be, whether it's substance abuse, mental health, which increases, costs for themselves, but also increase costs for us as building operators when buildings are, harshly utilized during the course of a tenancy. So yes, I think these types of programs, this one's in particular, and we've had some tragedies, obviously, that we relate to people's mental health issues during the course of our operations, and any chance to reduce those tragedies or consequences is a reducing factor.
And then, Dr. No, I know we only have one question left. If we think we can answer it very quickly, because I know we're coming at time here. So I'll let you maybe address that quickly, and then I'll close us out.
Yeah, I'll pass it over to Nora. So the question is from Stephanie Hartsfield on, does Hyphen integrate data with healthcare providers as well as housing and CBOs?
Yeah, so quick answer is yes, they can integrate. I'm not the best person to talk about it, but what we do is that on a case-by-case basis, we connect the Hyphen team with the tech team from the CBO or from the healthcare practice to figure out the right pathway of integration of the platforms. That's how we handle it.
Great. Beautifully done, Nora. Thank you so much. Okay, so I know we're at time. I appreciate everyone joining and listening in to some updates from the research team. And I also appreciate the research team and partners joining today to provide an update on your end. I know we'll expect another presentation in about another year. So we'll have some other updates, and we'll make sure to keep everyone updated on when the next presentation might be. But for now, I hope everyone has a great rest of their day, and we will be emailing the slides and recording out in the next day or two.
Great. Thank you so much for a great discussion. Great questions, everybody.